Thrombosis and associated thrombotic disorders occur when blood clots form seemingly spontaneously in the body. This results from the body being in a hypercoagulable state. This is a condition in which there is an abnormally increased tendency toward blood clotting or coagulation. There are numerous hypercoagulable states, some of which we will be discussing. Emboli are thrombi fragments that get loose from a venous thrombus and after moving through the heart may get lodged into the pulmonary arteries, causing ischemia and necrosis of the lung. The majority of emboli originate in the deep leg veins. Thrombophilia is the predisposition to thrombosis. Thrombosis can occur either in veins or in arteries. So, what's the difference? With venous thrombosis, we are talking mostly about DVT, or deep vein thrombosis. These form in the iliac, popliteal, and femoral veins, but can also form in the extremities and organs such as the liver, spleen, intestines, brain, and kidneys. With arterial thrombosis, blood clots form in an artery. Blood clots can obstruct or stop the flow of blood to major organs, such as the heart or brain, leading to, you guessed it, ischemia and necrosis. If a blood clot narrows one or more of the arteries leading to the heart, muscle pain known as angina can occur. Pulmonary emboli are thrombi fragments that get loose from a venous thrombus and after moving through the heart get lodged in the pulmonary arteries, causing lung damage. And again, the majority of these form in the deep leg veins. Approximately 85% of myocardial infarcts and strokes are caused by thrombi. For instance, an MI can occur due to thrombi lodged in the coronary arteries. Most of these events are associated with atherosclerosis. There are numerous risk factors associated with thrombosis. The risk of a thrombotic event increases with age. After the age of 50, the risk is higher. Diet is another factor, especially fatty foods. Lipid disorders such as hyperlipidemia, hypercholesterolemia, and dyslipidemia. Being immobilized for long periods, such as being in a plane, being a long-haul truck driver, or even being in a wheelchair can result in increased blood pressure. Birth control pills, pregnancy, hormone replacement therapy, smoking, inflammation, leg fractures, surgeries, particularly knee and hip replacements, antiphospholipid syndrome, which results in production of antiphospholipid antibodies, usually in autoimmune diseases, myeloproliferative disorders such as essential thrombocythemia, polycythemia vera, and CML due to hyperactivity of platelets, acute leukemia, tissue factor producing neoplasms, liver disease, PNH platelet-related thrombosis, since paroxysmal nocturnal hemoglobinuria is a stem cell mutation that results in, among other things, modification or even inactivation of platelet activation receptors, chronic inflammation, and congestive heart failure. Just as with risk factors, there are several conditions that predispose individuals to thrombosis. However, unlike the risk factors, I'm not reading the entire list. I'll just say that some of these are congenital, some can be acquired, and some can be both. This is the list of lab tests that can aid in diagnosing and monitoring patients with thrombotic disorders. The lupus anticoagulant, antithrombin, protein C, and protein S assays should be performed at least 14 days after discontinuing anticoagulation therapy. This is important because anticoagulants like vitamin K antagonists and heparin are particularly problematic for laboratory testing. Once patients are on anticoagulant therapy, any attempt at laboratory testing for investigation of likely thrombophilia markers will result in erroneous results. This is because most hemostasis tests, including those commonly used to assess the prothrombotic status of a patient who has had a thrombotic event, they're significantly affected by anticoagulant therapy. It may be surprising to some of you just how many physicians really don't realize this simple fact. So, first up on the list of thrombotic disorders is DIC, or disseminated intravascular coagulopathy, also called defibrillation syndrome or consumption coagulopathy. This is a very serious condition that is essentially a generalized activation of secondary hemostasis. It often develops secondary to a systemic disease or some other event. DIC causes the formation of microthrombi throughout the circulatory system that can cause partial occlusion in tissues and organs, resulting in ischemia and necrosis. The reason that this condition is also known as consumption coagulopathy is due to the consumption of coagulation factors, enzymes, control proteins, and even platelets, which leads to widespread hemorrhaging. Several triggers may stimulate the initiation of DIC. Some of these triggers are substances, while others are events. For example, the release of tissue factor due to trauma or monocyte activation, or tissue factor from exposed endothelium to the extreme vasodilation, can initiate DIC. Toxins produced by pathogens, such as bacteria, fungi, and protozoa, as well as endotoxin, remember what that is? They can be a trigger as well. Immune complexes in circulation, which can be due to certain drugs that induce an immune response or hemolytic transfusion reactions. Thrombotic diseases like thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. Also, platelet activation, which can occur with vascular surgeries like cardiac bypass and placement of vascular prosthesis. And then there are other potential causes, such as diabetes, hemotoxins from venomous snake bites, chronic inflammation, and even pregnancy. There are both acute and chronic causes of DIC. Acute causes are often uncompensated and often fatal, whereas chronic causes are more likely to be compensated by the liver and bone marrow. Patients with a chronic condition as a cause may even have normal or increased factor levels. The liver compensates by upregulating production of coagulation factors, while the bone marrow upregulates the production of platelets. It's important to note that some cancers are more prone to cause DIC than others, such as multiple myeloma, adenocarcinoma, pancreatic, ovarian, prostatic, and lung cancer. The tests included on a DIC panel will vary from institution to institution, and some institutions may not have a formal DIC panel at all. However, the tests listed on this slide include tests applicable to DIC, which includes a blood film examination, platelet count, ProTime, PTT, D-dimer, and fibrinogen level. In DIC, fibrinogen is consumed, resulting in low levels in circulation, the exception being when an inflammatory process already exists, because in that case, fibrinogen may already be increased because it's an acute phase reactant. The reference range for D-dimer varies a lot from reference to reference. It appears to vary with the methodology. So, for instance, if you refer to your textbook, RODAC 5th edition, it gives a range of 110 to 240 nanograms per mil for the D-dimer quantitative immunoassay. However, on page 783, it says that fibrinogen degradation products and D-dimers normally circulate at levels of less than 2 nanograms per mil. And on page 705, table 39-15, it says 0 to 240 nanograms per mil. So, yeah, go figure. Several conditions may lead to DIC, but once DIC begins, it all progresses in the same manner. Thrombin is formed systemically, not locally, which results in the formation of microthrombi in circulation. Normally, fibrin monomers polymerize spontaneously, so the polymers help consolidate the clot. But with DIC, the monomers do not polymerize, or not many of them do. Tissue plasminogen activator, derived from the injured endothelium, binds to fibrin and activates plasma plasminogen, which becomes plasmin in the vicinity of the injury. Plasmin then breaks down fibrin from the fibrin clot, releasing fibrin degradation products, or FDPs. Those include D, E, X, Y, and D-dimers. In DIC, the formation of microthrombi is happening everywhere in the vascular system, and at the same time, a certain percentage of the fibrin monomers do not polymerize. These are soluble and move freely in the blood. All forms of fibrin bind to plasminogen and activate it to plasmin, which can then degrade all forms of fibrin anywhere in the blood: monomers, multimers, and cross-linked polymers. For this reason, in DIC, we end up with elevated levels of FDPs everywhere in the body, including D-dimers. In addition, plasmin also digests other clotting factors, which include 5, 8, 9, and 10, and triggers complement, resulting in inflammation. The presence of D-dimers confirms active fibrinolysis and, indirectly, of the occurrence of thrombosis. Normally, FDPs, including D-dimers, are present at a concentration less than about 2 nanograms per mil. Fibrinolysis yields values of FDPs and D-dimers generally above 200 nanograms per mil. Increased values are consistent with DIC, systemic fibrinolysis, deep vein thrombosis, pulmonary embolism, and thrombolytic therapy, but the levels vary between conditions. In DIC, though, the levels are much, much higher. Both automated and manual methods are available for D-dimer testing. Manual methods are typically latex agglutination tests, while automated tests are based either on turbidimetry or nephelometry. The sensitivity of ELISA assays varies depending on the avidity of the monoclonal anti-D-dimer antibodies and the detection method used, but most are able to detect levels as low as 10 nanograms per mil. Methods with a high sensitivity but low specificity are used to rule out vascular thrombotic events, or VTE, but not for diagnosing it because there are many false positive results. Latex particle agglutination tests are much less sensitive, detecting greater than 500 nanograms per mil, but have a higher specificity. They are used for detecting DIC, but not for VTE, as there are many false negative results.